Welcome back to Therapeutics. In this block, we're going to review headache, and a fair number of things have changed over the last 2 to 3 years in particularly migraine headache. And so we'll try to walk through some of the older school and some of the newer agents that are on the market for which a lot of clinicians are still trying to determine where the practice guidelines are and where some of these newer therapies fit. So I'll try to give you a sense of where we are at the current time with that and get a sense that over the next maybe 3 to 5 years, we may see some evolving changes in which agents are first and second line. So as we look at headache, we want to be able to differentiate the types of headache, specifically concerning, do we have a migraine headache? Is it a tension headache? Is it a cluster headache? And we're really going to focus on the treatments for migraine here, not too much on the other types of headache. And also headache as an indicator of other pathology. So again, I'm going to leave that to the Clin Med folks to talk with you about, the thunderclap headache, the worst headache of your life concerning, is there a bleed? Is there a tumor? Is there something else that you need to sort of work out? So we're going to look at some of the differentiating the types of treatments for headache and really focusing again on migraine here. So the classic migraine headache, and it happens in maybe 1 out of 5 to 1 out of 6 women, and maybe 1 out of 20 men. Although migraines can have varying presentation styles, and we consider the nature of classic migraine typically has an aura associated with it. That might be nausea, vomiting. It might be a sense of light, flashing, or sounds that are disturbing. And most often there are also triggers to migraine. But not every migraine has an aura. There are migraines that happen without aura. So there's even ocular migraines that really pretty much look like zigzag lines in the back of someone's eyes, almost like thunderbolts. So you'll find that there are varying presentations for how a migraine headache may present. But typically, patients who are undergoing a migraine will often complain of nausea, vomiting, and photophobia or phonophobia, difficulty with lights, particularly bright lights, or difficulty with sound. And a lot of patients will tell you that when they have a significant migraine headache, it will be debilitating for them, and they just need to go lay down in a dark, quiet room. And so that's often, we kind of look at the things that trigger a migraine and the things that make a migraine worse when they're happening. Let's briefly talk about the other types of headache, and we won't really spend much time about the therapeutics here. The tension headache is the very most common type of headache most people will have. They may describe it as a tightening band around often their forehead or their temple areas, and they typically will not always notice an aggravating factor, but often it's tension or stress that do it. And our treatment options there typically are, first of all, making sure folks have adequate rest, avoiding triggers for a tension headache, reducing stress, sleeping well, eating well, all the kind of lifestyle things we recommend for just good, healthy patients anyway. Cluster headaches happen much less frequently and are seen more often in men than women. These can be severe and often have either unilateral and a sort of orbital eye pain that is very significant behind the eye. And when patients have this, you kind of think of it, it's different sort of than the eye pain itself. It's really pain from more or less what people will tell you is behind the eye. And they will often have, their eyes will be irritated, they'll be tearing, have maybe concurrent nasal congestion or rhinorrhea with facial sweating. It's miserable for them. And the treatment of choice here is often, again, environmental changes, but of all things, oxygen seem to has the best track record with cluster headaches. So giving supplemental oxygen. And another type of headache we want to be aware of is analgesic rebound headaches. These happen with folks who have been on, acetaminophen or a nonsteroidal or other pain management meds, even opioids, repeatedly, and then they found that they develop a rebound headache either while they're on it or going through withdrawal of those treatment options. And the answer really is to look at stopping those therapies long term, even though recognizing that in the short term, 24 hours, that may get worse before it gets better. But you want to be cognizant of if a headache doesn't present in a classic way and the person's been popping lots of analgesics, particularly over the counter, but also opioids or others, you want to really be aware that that can be problematic. So let's look at our treatment of acute migraines. When patients are undergoing an acute migraine, we have a number of therapies we use for treating a migraine that is evolving. And so patients, you may see these patients in the emergency room or in the clinic where they have an acute migraine in front of you and they need to get that aborted as fast as they can. And then we'll talk a bit about the therapies we have for prophylaxis of migraines, preventing a future migraine. And those therapies historically didn't help acute attacks, and the acute treatments didn't help, prevent future migraine attacks. That's kind of changing, and we'll get to some of the newer therapies that are available that may have a role in both uh, aborting an acute attack and preventing a future attack. But let's hold that thought for a minute. The first line therapies for acute migraine is pretty much established in the last decade to 2 decades of the triptans. There are a number of them. Sumatriptan is probably the classic one we think of. It's a vasoconstrictor. It's available by subcutaneous route, intranasal, oral, rapidly dissolving oral for folks who have a lot of nausea, vomiting associated with their migraine. And the good news is that they are pretty effective at aborting migraine. The bad news is that they are vasoconstrictive. That's how they will work in acute migraines. Um, and so folks who have, or patients who have an existing issue with coronary artery disease or stroke or uncontrolled hypertension, peripheral vascular disease, ischemic bowel, women who are pregnant, these are all patients who should really avoid the vasoconstrictors for acute migraine management. And so we now have some newer therapies we'll talk about in a few minutes. But other than that, if you don't have a major contraindication for using them, the triptans are tried and true. Most patients tolerate them pretty well. They are effective. They are becoming much, more cost effective for patients than when they first came out. And so the rule of thumb most clinicians will go with, and we'll talk about some evolving guidelines at this point in time, is to consider a failure of 2 different triptan formulations before you consider moving on to other therapies for acute treatment of a migraine. So the issues we think of with these agents, they pretty much work against serotonin receptors, the 5-hydroxytryptamine 1 serotonin receptor, resulting in vasoconstrictor restriction action. They are pretty well absorbed orally. They also have other routes of administration. Subcutaneous is one of them. Intranasal is one of them. And so we are aware that their options just probably want to match the triptan to the route of administration and the way this patient's migraine sort of manifests, and then look at the kind of side effects profile you might see. Most folks do quite well. Sometimes they'll have an injection site reaction for the sub-Q forms, and some folks feel a little off, tingling or sort of atypical sensations. Sometimes it's hard to know, is that the migraine or is that the triptan doing that? But you kind of want to recognize that a lot of folks will have sort of varying degrees of side effects. Most patients will tell you, if it works, that the side effects are tolerable compared to the migraine. And if it works to abort the migraine, most patients are sort of happy to have an option to abort a migraine. The contraindications as we look at with these drugs, or anybody with an issue with vasoconstriction, so would worry about anything, any patient who has IV drug abuse history, patients who have ischemic heart disease, really uncontrolled hypertension, just modest hypertension in good control probably is not a contraindication. And there are lots of different triptans that are available. And there's a table in a bit that will sort of outline some of the varying products that are available, both as the drug and the route of administration and the regimens that are available. The older ergot alkaloids, we don't use these much anymore. These are the older vasoconstrictive agents that were around before the triptans came out, maybe in the late 1980s, 1990s. Ergot alkaloids had historically been the agents we used before the triptans. It's pretty rare to see them, but on occasion you may see a patient who is on an ergot alkaloid vasoconstrictor for migraine who hasn't tolerated triptans for one reason or another. But keep in mind that these are also vasoconstrictive, so they would also be considered contraindicated in folks with stroke, coronary artery disease, peripheral vascular disease. All the issues would be concerned about with avoiding the triptans as well. And so, there's some data about where they work and how they prevent migraine headaches, but I wouldn't focus too much on the ergot alkaloids because we don't use them much anymore. Again, some adverse effects for them, but again, not very commonly used. There are some other things that are also used in migraine headaches, and some of them are listed here, not all of them. Opioids, we usually try to avoid opioids in management of a migraine unless we have no other alternative, because giving opioids to a patient who has repeated migraines for acute management will ultimately lead likely to habituation to opioids. By the nature of the control of the migraine, it's just really something clinicians try to avoid. There are other products as well, but probably the most common thing we'll add to migraine regimens is an antiemetic. And there's different antiemetics we'll talk about more in the GI block. But when you think about antiemetics, if the patient has significant nausea, vomiting, any of the antiemetics can work well. More commonly, I guess, would use ondansetron if it's nausea before vomiting is happening. But once vomiting happens, we have to often up the ante with other agents as well. Folks who have repeated migraines sometimes will look at other therapies that are listed here as well. But those, with the sort of the newer therapies out, we don't see them used very much. And let me just talk about an old school regimen that is still surprisingly widely used, for which there is sort of limited real data on, but as a practice continues, is the use of something called Fioricet or Fiorinol. Is a barbiturate in combination with caffeine and acetaminophen or aspirin. And this formulation has been used for years and years and years for folks who have sort of a headache. Classically, I guess would say a migraine type headache, but other headaches as well. Caffeine makes sense a little bit because it's vasoconstrictive, but caffeine also is associated with, for some folks, withdrawal phenomenon, significant headaches with withdrawal, and caffeine can be associated with repeated headaches and triggering migraine headaches for some patients as well. So caffeine is not a great choice for migraine. The other things that people will talk about for migraines that they sometimes try is a nonsteroidal and or acetaminophen with caffeine. Excedrin, for example, is sort of classic. Sometimes aspirin plus acetaminophen plus caffeine. All of these can be used for varying headaches, including migraine as an early option. So the first-line treatments for migraines, here is the table of the triptans. The triptans pretty commonly used. I think most clinicians will find that these are what you sort of match one of these to the patient. What is the significance for the side effect profile for the patient? Can they take an oral or an oral disintegrating tablet? Do they need sub-Q? Do they need intranasal? Do they need something else? And so there's, the choice is sort of made there. There are a couple other options here as well. There's sumatriptan with naproxen available as a combination product that could be considered. I don't really see an advantage for that compared to just going with a standard, separate therapies as well. And the ergot alkaloids are still available, just not very often used anymore. Let's now go to what's happened in the last 3 years. There are sort of new treatments for acute migraine, and some of these have some evolving data for prevention of migraines as well, which is kind of exciting news. The GPANTs, first of all, are the GFRP receptor antagonists. These are seen to be triggered. It's a particular substance that's triggered in a migraine headache that by antagonizing this action immediately can abort a migraine. And so the GPANTs are becoming sort of a new line of therapy. Most clinicians, though, are hesitant about ordering these right away until more data evolves, and at least as of mid 2022, the guidelines really have not been formally established for where these agents really fit. There's been a number of studies that have been published, but the guidelines are evolving and clinicians are sort of looking where they fit. I'd encourage you to look at this table just quickly to get an idea that these agents, which are really pretty much second line now for acute migraine management and even for prophylaxis, not first line, these agents have some roles, but they have a lot of drug interactions with the cytochrome P450 enzyme systems. And so you want to kind of be aware of that, and they're pretty pricey. So an insurer may not require a prior auth for it or have failed two triptans before they'll sort of cover it at any sort of stage at all. There's also a serotonin agonist that's similar to triptans but doesn't have the vasoconstrictor. That's kind of exciting, the ditins. And Rayvow is really the first in this group. There's not a ton of data here. It's a fairly new class of agents. There are interactions with P-glycoprotein inhibitors, and that's also true with some of the other GPANTs as well. It's a Schedule 5 drug. The ongoing safety and efficacy is evolving with all of these new agents. And there really aren't a lot of data comparing them head-to-head with triptans. And so, what we don't really know is, are they better than triptans, short and long term? Are they safer than triptans, short and long term? We don't know that. So we're kind of waiting for that kind of evolution of data to happen. And so a lot of clinicians, you've heard me or throughout the year kind of talk about how I don't like to be the first on a bandwagon for a new modality unless it's revolutionary. These are becoming somewhat revolutionary. I think for the right patient, they can really make sense. When you can't use a triptan, this might be the next line of therapy. So I think clinicians are sort of looking at that. So here's the first of these calcitonin gene-related peptide antagonist agents. And this one data was published in late 2019 and became on the market in 2020. Really indicated that it was pretty effective at aborting an existing migraine compared to placebo. Here's a chart that explains that. Now, notice that even some patients with placebo, half of patients had an abort of their migraine within 8 hours. That's a long time for somebody who's got a significant migraine headache. And so they offered significant benefit. And so this is pretty good data. I don't know that it's really better than the triptans, and we don't have that direct comparison to make. The other thing I'll sort of allude to, and we'll talk about this a bit later, is that some of these very agents are undergoing studies as we speak that look at different phases of studies, phase 2, phase 3 studies that are ongoing for their use for acute and for prophylaxis or prevention of migraines. And so the data is evolving for where these agents will fit, how effective they are, what comparatives they have, and whether or not a single agent could serve as both prevention and treatment. So expect that is evolving. You're going to see that is happening. In fact, there's already some direct-to-consumer advertising that's suggestive that these treatments are revolutionary. Just keep in mind when patients come to you asking for them, there's not a lot of long-term data, and you likely will reach a speed bump for getting them reimbursed. There are some other things here about the nature of some of these agents as it relates to pharmacokinetics and their hepatic metabolism by cytochrome P453A4. And so you want to watch for a lot of drug interactions and potential protein binding interactions with some of these drugs. So you want to be aware of that if you were to consider some of these newer agents. So in summary, for acute migraine, this is kind of a busy graphic, but you may want to sort of stop and then sort of expand this slide and look at it. The rule of thumb generally at this point in mid-2022, most clinicians are sort of evolving where do the new agents fit. But most folks will look at, first of all, identifying, have a patient keep a headache log, look for what are the triggers in their migraine and avoiding those, making sure they have appropriate wellness care for sleep and eating, limiting caffeine, relaxation therapy, biofeedback, cognitive therapy, anything that's going to sort of look at improving the overall quality of life for folks. And then if they have mild to moderate pain severity, typically folks will start off with an NSAID and or acetaminophen, sometimes with caffeine, but caffeine is sort of good bad news here. It may help with the acute migraine, but sometimes it triggers sort of worsening migraines for folks. So generally we look at limiting caffeine, even though they may help in the short term, they can make future migraines more problematic for a lot of folks. If they need antiemetics, then adding the appropriate antiemetic on board. I think ondansetron is probably what most clinicians would look at if it's just nausea. And if they have vomiting, you may need to sort of go up the ladder on that. If their severity is more significant or they have a lack of response to NSAIDs or acetaminophen, then triptans make sense. And then looking at triptans, modifying that in relationship to, do you need an oral therapy, sub-Q, nasal, what's covered by their insurance plan. And for the most part, we're looking at most clinicians right now in mid-2022 will look at having sort of tweaked one triptan with antiemetic therapy if need be. And then if that fails, try a second triptan before you go to one of the newer agents. So looking at some of the newer oral agents for treating an acute migraine would be sort of limited after you've failed 2 trials of triptans. What's not on this slide are some of the older therapy. You don't see ergots on here. You don't see some of the other therapies on here. But there might be a niche for some of those older therapies as well. But a lot of clinicians really probably wouldn't be doing that. Okay, for prophylaxis, the issues I think most clinicians will do is to look at considering prophylactic therapy if the headaches are frequent. And you want to look at sets of guidelines. And I think in ClinMed, you may kind of determine this as well. Most folks, when they have somebody who has significant migraines frequently, multiple times a month, they may start looking at managing them in primary care, but they're just as likely to sort of have them seen by the neurology clinic, the pain clinic, the headache clinic that's available in the area. And a lot of folks will look at where they're tracking their frequency of migraines, the severity of the migraines, how incapacitating they are, and then what are the treatment options that are available for prophylaxis for migraine. The older therapies for migraine have been around for some of them for more than a generation. And these have been tried and true. They're cheap. The first one I think that we'd look at are beta blockers. Propranolol or timolol oral therapy, long-term propranolol has sort of been the tried and true prophylactic migraine headache regimen for decades. A lot of folks will report some improvement, others will not. A couple other sort of niche agents in here that might be used, topiramate or Topamax, the anti-seizure med, has had a moderately reasonable track record for prophylaxis of migraines. That's sometimes considered. The big downside to topiramate are kidney stones. So if a patient has a history of kidney stones, probably want to avoid that. Valproic acid has been tried. Valproic acid has a lot of side effects, weight gain and risk for pancreatitis and liver injury. Those are kind of minor. Thrombocytopenia. So a lot of clinicians probably would think valproate is probably going to be limited when other things fail. And then probably the more common trial agent that's going to be used in migraine headache prophylaxis is Botox or a botulinum toxin. That's been around for the last decade or more, and headache clinics have good experience with that. So that's pretty commonly used. The rest of the therapies that are listed on this page, the tricyclic antidepressants like amitriptyline could be tried, particularly if you have neuropathic pain associated with it. The patient is well, recognizing the limits to that therapy. The other therapies that are listed on here have less significant, data associated with the efficacy and safety. And then there are some other older agents that have, very limited data. But if you have another reason to use one of the drugs on this slide, it may make sense to use it for that and see if the migraine headaches are improved with patients as well. But the data here for these agents is less tried and true. So let's look at where things are now in the last 3 years. There are a couple of new things on the block. The newest group of agents on the block are monoclonal antibodies directed against this calcitonin gene-related peptide. And they're, I think a lot of clinicians are waiting for more experience, more seasoned practice guidelines becoming available to see on where they fit. So my sense would be, I don't know this, but my sense is that these are pretty much going to be limited to the headache clinic or the neurology clinic that is managing them in the short term. I think you'll likely have some hesitancy on the part of an insurer to cover these therapies that are considerably more expensive than the older regimens are. There are, in this slide, some recommended guidelines from the American Headache Society that looks at who might be candidates for one of these monoclonal antibodies. And it depends on, how long they've had their diagnosis and whether or not their response has been robust with other therapies or not, and how debilitating those headaches are. And so, again, I think that in most patients, you can sort of see as examples of therapies that have failed. Again, topiramate, divalproex, beta blockers, amitriptyline, nortriptyline, antidepressants. These are sort of the candidates for whom you would probably consider one of these modalities. And again, you might have to demonstrate failure on them to get insurance coverage. Here's a nice little chart that compares some of the older oral migraine prevention drugs, the beta blockers and topiramate and valproate, the anti-seizure drugs or the beta blockers, versus botulinum toxin versus the calcitonin gene-related peptide monoclonal antibodies. What you don't see on this comparative table are the GRPs agents that are oral that are used for sort of acute migraine that are evolving for prophylaxis. But that be said, I'd encourage you to quickly look at this table to compare them on indications, dosing, adverse effect profiles, and the like. I think you're going to find that in primary care, as of 2022, we're still using the oral migraine prevention drugs, and then if those aren't effective, send them off to the headache clinic for botulinum toxin and or for one of the monoclonal antibodies. The data for the GPANTs, as we alluded to a minute ago, which aren't in that prior table, the data is undergoing evaluation. There are ongoing studies now that will sort of allude to whether or not how robust the data is for acute and for prevention of migraine. And whether an agent can sort of do both or not. So I think you'll find that some of these agents are evolving, and expect that in the next couple of years, these GPANTs may become first-line therapies for both acute migraine abortion and aborting an acute attack and preventing a future attack. But to my knowledge, these agents are still relatively new on the block. Clinicians don't really know quite their long-term safety and efficacy data, and we're kind of waiting for these trials and more clinical experience to sort of pan out before sort of we jump on this bandwagon. Okay, The other issues we look at for tension headaches, there are, some of these same therapies are sometimes used for that. But I think for tension headaches, very common, you'll see acetaminophen and or nonsteroidals with caffeine. And for prophylaxis of severe migraine headaches, whether antidepressants or botulinum toxin help in those circumstances, the data, I don't have a lot of experience with that. And for most patients, I think the answer really with tension headaches is to reduce stress, improve sleep patterns, do all of the things you're going to do to help manage a patient with significant lifestyle issues interfering with their headaches. Okay?